ladies and gentlemen, my name is Saraset Thanaset. This is my great honor to be your MC of this afternoon. I think all of us will really enjoy about the break, the ice cream, right? Before we start the next session, I have something to announce. First of all, please don't forget to give us a valuable evaluation via the QR code that help us to be improved for our next conference. And everyone who join in the evaluation will be take a part in the lucky draw in this evening for 3 more prizes about the 30th anniversary memorial shirt of Silas Pain Clinic. And another one we will announce in Thai because it's about Thai textbook. ตอนนี้เรามีหนังสือ Acute Pain Management นะครับกำลังจะวางจำหน่ายในช่วงต้นเดือนหน้านะครับตอนนี้คือสามารถสั่งจองล่วงหน้าได้ข้อดีของการสั่งจองล่วงหน้าตอนนี้ครับคือเราจะจัดส่งให้ฟรีนะครับนะไม่คิดค่าส่งนะครับผมนะก็เป็นหนังสือที่ดีมากนะครับเกี่ยวกับ Acute Pain Management นะครับ complete นะครับเดี๋ยวมีรูปตัวอย่างให้ดูนะครับเดี๋ยวเราดูรูปแป๊บหนึ่งนะฮะรูปผมไม่ต้องดูนะฮะดูรูปหนังสือนะครับโอเคนะครับก็5 กุมภาพันธ์นะครับตัวจริงจะออกนะครับตอนนี้กำลังจัดส่งโรงพิมพ์นะครับถ้าท่านใดมีเวลานะครับหลังจาก5 กุมภาพันธ์มาซื้อในโรงพยาบาลจะได้ลดราคา 10% นะครับก็จะเหลือ540 บาทนะครับผมมี specific นะครับ Okay, so the next session will be very interesting session about the common intervention for cancer pain, and it's my great pleasure to introduce Assistant Professor Prani Ratchamukhayanan as a moderator in this session. Please give her a warm welcome.
Good afternoon again after a big meal. I hope everyone is happy with Thai food. Okay, so this afternoon session, still we carry on with the cancer theme of today. It will be more exciting before the workshop for tomorrow. Tomorrow we have workshop for intervention for cancer pain as well. May I introduce Assistant Professor in Pain Medicine, Carlos Roden, and he also Professor in Emergency Medicine from MD Anderson Cancer Center. Please welcome to Dr. Carlos. So for those who are not anesthesiologists, it's a good introduction that you can listen to his lecture and to see that your patient may be suitable for the intervention, okay? Okay, please, doctor.
Good afternoon. My first time in Thailand, as I mentioned before, so I was asking about what if you have Uber or what kind of way to transportation here in the city, and I was recommended Grab, so I downloaded the application, and yesterday I was moving to a different hotel, and then I requested the service, and I had luggage and my brother, and then the Grab service came, and it was a motorcycle. So I just realized that I hit the wrong, so it has a motorcycle, so you use it. For those who are not from Bangkok, just pay attention, you get a motorcycle. So anyway, I want to talk about procedures in cancers, but something that always gets my attention is what is cancer pain? You know, everybody talks about cancer pain, but is cancer pain that happens after cancer, pain that happens during cancer, or is pain that is completely related to cancer? So I had that question, so I think we had to spend a few minutes trying to define what is cancer pain, because there might be a lot of ambiguity, so we don't really know what we're talking about. So the first thing, I think probably the most important is to talk a little bit about the mechanisms of pain in cancer. So population is aging. The older we get, the higher the chances of getting pain. And the older we get, the higher the chance we're going to get cancer. So they're all back to back. Many conditions that used to kill us years ago, they're no longer the case. Now we have transplant, we have antibiotics, we have technology, we have dialysis, we have many things. So those patients that used to die from an infection or renal insufficiency or others, they're no longer dying. Now those people are surviving. So people are getting older, and therefore the rate of chronic pain is higher. It's expected to be epidemic. About 20% of the world population has chronic pain of any source. And again, because we're getting older, there's higher chance we're going to get more patients. And probably, hopefully, we will not. But as we get seniors, we might become chronic pain patients. So at least in the United States, by 2050, the population of older people is expected to outnumber younger people. So it's an aging country. So when you have a patient with cancer, there's a good chance that the patient is coming with chronic pain from other source. So not necessarily once you start seeing the patient diagnosed with cancer, this is something that is coming just with the diagnosis. There's no rule of exclusion. You can have pain from any source before you get diagnosed with cancer. And that's probably what I refer as a premorbid pain. Premorbid pain is by location, most commonly low back, 27%, headache, the neck pain, the facial pain, by cause, cancer, and I put cancer no as a redundancy. I've seen many of my patients that had gone to the third or fourth cancer. The highest I seen was a patient with 11 cancers. I couldn't believe it. She has survived 11 type of cancers, and they were documented in MD Anderson, and she looked okay, but 11 cancers, that's something you can imagine. Also by cause, commonly osteoarthritis and rheumatoid arthritis, then surgery and spinal pathology. That's premorbid pain. Now we have a patient that we're suspecting cancer. It was very interesting because I find a lot of literature in that type of patient. There's a retrospective study where out of 877 patients who underwent image-guided biopsy, 8.9%, almost 9% of those patients developed pain from the biopsy side. And this is not cancer yet. Probably many of those patients were already diagnosed or confirmed to have cancer, but they already have the pain associated to the biopsy itself. Surgical removal of tissue. In this one, it was also interesting. Patients who underwent prophylactic mastectomy, partial, complete, and even some with reconstruction. Overall, 20 to 30% of those patients develop chronic pain, and that's still not cancer-related. So some of them might already have cancer, but so they'll develop the pain from the procedure itself. Lines and catheters that we place for cancer patients have also been associated with chronic pain. In this particular study, they didn't decide what was chronic pain, but they defined it as a prolonged use of analgesics. So it wasn't clear if entered for our definitions of chronic pain. This one is something that we published, Dr. Han, Dr. Chai, with myself, we published at the end of last year. It was very interesting, the patients that underwent bone marrow aspiration. Close to 5% of those patients developed sacroiliac pain just from the bone marrow aspiration itself. So these patients might be coming with other type of problems, but now they have pain from other source, not necessarily cancer itself. Very interesting, even that is not my background, I'm always interested in the body mechanics because the body functions as a symmetric entity. So as you alter the symmetric proportion of any structure, either anatomically or functionally, that enter some changes into the body, you have to adjust. If you have a neuropathy, if you develop pain in one knee, you're going to start using your body in a different way to compensate. So you might actually develop pain in other locations that have nothing to do with your knee. Same thing with cancer. So structural functional deficiencies result in body compensation at other levels. That's something that I see all the time. I see a lot of my patients that come with a lot of pain, and then you realize that has nothing to do with cancer. They might have developed the pain from something else. That applies to this. This is a very common pathology in the cancer patients. So facet spondylosis is presumably to be the cause of low back pain in up to 45% of the population, non-cancer population, and also up to 55% of the population of the neck pain in patients in the general population. However, the cancer pain has additional risk factors to develop facet spondylosis. So there's aging, yes. All cancer patients are usually older, and the older we get, the more chances for cancer. Also more chances of developing lumbar facet spondylosis. Same thing, those patients are subject to abnormal motion and positioning, degeneration of synovia, capsular stretch, cartilage degeneration, and others. Those patients get radiation therapy, those patients get a lot of steroids, they get other hormonal therapies, and those are risk factors for you to develop lumbar facets or facets overall spondylosis. That might be the pain, even still we're talking about nothing to do with cancer, something unrelated. Similarly to sacroiliac pain, sacroiliac joint pain is estimated to be up to 25% of low back pain in general population. However, we're going back to the same thing. Cancer patients have higher risk factors to develop sacroiliac pain, even if it has nothing to do with cancer. Gravity challenged patients, what I mean by gravity challenged patients, I'm talking of patients in wheelchairs, patients that need walkers, patients that are bedridden, are higher risk to develop sacroiliac pain. Length discrepancy, 1 centimeter of length discrepancy can translate into five times the load asymmetry that the patient is subject to into the sacroiliac joints. So if you when you're talking about cancer, you're just thinking of the tumor. You're not thinking about other things that can be actually as a result of. Same thing with weight distribution, hormonal changes, etc. Many of the cancers that we see, patients have a lot of inflammatory pain. Excuse me. So we go back to ergonomics. Patients, as they develop something, I've seen patients that unconsciously, even with a tumor that is not hurting, they start doing avoidance positions. They know they have a tumor in the liver. Doesn't hurt, but probably unconsciously they start adopting positions in avoidance, compensations of comfort pain. And then they start getting pain anywhere else that has nothing to do. So with that, people do underuse, overuse, changes in distribution of weight, many things that can actually translate in affections. So tendonitis, bursitis, ligament issues, muscle injury that is still unrelated to cancer. So I hope I made my point with this. Therapy-based, of course, we know that about 20% of the population with cancer, they get pain secondary to therapy itself. Surgery is one of well-known causes of pain in the cancer population. Surgical procedures and post-surgery complications. How about the patient that need to get surgery multiple times? Every time they get an additional procedure, an additional surgery, the pain is going to change, and probably the chances of developing chronic pain in that particular area is much higher. Thoracotomy patients are estimated to develop chronic pain up to 70% of the cases. Limb amputations, 100% of the patients get phantom symptoms, but a high number, they might get a pain as well. Functional outcome, I think this is very important because we're not necessarily talking about physical pain, but think of the patient that gets, after surgery, disfiguration of the body. Many of them, they lose bowel or bladder function, sexual dysfunction, many other things. That's disfiguration of those patients that can affect the patient psychologically, and therefore the sphere of pain gets even bigger. Radiation therapy, one of the things that I see a lot with my radiation patients, post-radiation therapy, is neuropathic pain. Interestingly, I was reading some articles that the nerve is one of the most resistant tissues to radiation therapy. However, there's something called the bystander effect. Bystander effect refers to tissue that is in the proximity of the area that is being radiated, and this bystander effect, the tissue, the anatomy and the histology of the tissue around changes, even that it was not directly irradiated. Poor healing and pretty much fibrosis. What used to be elastic and healthy becomes like leather, doesn't heal, and it doesn't respond well to therapy, and is one of the areas that develop pain as well. So about 5% of the people that receive radiation therapy and for breast cancer, they can develop plexopathy, brachial plexopathy. We see that quite often. People with prostate cancer, about 20% of them, they develop also dysuria, burning and pain to urination. You can explain it. There's no tumor anymore, but the patient had the radiation. So those are pain syndromes that we see frequently in those patients. In chemotherapy, I don't have to extend about that. When I talk about chemotherapy, I'm not just referring to the specific treatments that we use for cancer. We're talking about other things that come with it. Patients with the high doses of steroids, it's very common they develop a vascular necrosis of the joints, shoulders, hips, knees, hormonal therapy. I see a lot of my patients, prostate cancers, patients with the gynecological cancer, they get hormonal therapy. And by those hormonal changes, many patients develop migraine. Migraine is, one of the factors that pretty much regulates the frequency and intensity of migraines, hormonal changes. That's why migraine is very common in teenager females, but that would be the equivalent. A male getting hormonal therapy for prostate cancer, they start getting a lot of headaches. That's also another type of probably associated to the treatment. Growth factors that can cause a lot of muscle and joint pain, immunotherapy, and etc. So all of those things are pain that we need to treat. So when I go back and say, what is cancer pain? I don't know the answer, because the literature, when you read the statements, you see that depending on how advanced the cancer is, the chances are you're going to have more pain. But what percentage of that cancer pain is really secondary to the tumor itself? So many of those numbers might actually be in this, so we don't know exactly which one is and which is not. What I wanted to make clear is because the reason I brought this up is because when we're talking about procedures for cancer, pretty much every procedure that you do for the chronic pain also applies to cancer. So you do the same injections, the same joint injections, same nerve blocks, the same trigger points, everything else that you do applies for the cancer patient. Now, I'm gonna mention a few procedures that are specific for the cancer-related patients. So I'm not gonna go back and mention every single thing that we do in pain, but this is probably some of the common things that we do. But we have another problem. It's very exciting to talk about procedures, the nerve block that is gonna cover the pain in question. However, the complexity of the cancer pain is significant. Many patients, they do require a procedure. Maybe you feel like that procedure will be specific for that patient. Unfortunately, we see those patients that are too weak, they're too sick, they're intubated, they're in the ICU, they are dying, and even that you would like to do the procedure, you probably shouldn't. Patient is too sick to undergo a procedure. They can be invasive. Many of those patients are immunosuppressed, they are neutropenic, thrombocytopenic, they are anticoagulated, they have renal failure, they have a liver failure. So there's many things that you have to put in perspective before you say, yes, let's do the procedure. There's so many things that you have to think about. But even to make it more complex, some of those patients that you cannot do the procedure, they can also not take anything per mouth. Many of those patients, they have allergies, they have sensitivity, they have intolerance to certain medications. So the population with cancer pain is very complex. I don't have to tell you that. So I wasn't surprised by this statement with up to 82% of the patients with cancer pain, they are undertreated. We have too many limitations for that. With that being said, it's probably a good statement to say that all patients with cancer pain, they do need multidisciplinary and multimodal approach. Do not expect that just putting your needle and doing a block, you're gonna fix the problem, because it doesn't work like that. Now I'm gonna mention just a few procedures that we do and that we probably find that are very helpful for our patients. First one, I'm gonna talk about neurolysis and ablation. This type of procedure, we're targeting the fibers C and A delta. Those are the fibers that transmit pain. They are not to transmit vibration or touch, it's more for pain. With this kind of procedure, what we're doing is an intentional injury of the nerve or the plexus that we're trying to target. It's been seen through the literature that those procedures can actually be very helpful in improving the quality of life. Some papers state that 75% of the patients' quality of life improves. However, there are no papers, or probably there's no proof that those procedures will improve the survival of the patients. Maybe some not. So when we're doing those things, it's more to improve the quality of life of the patient. What kind of nerves do we target for neurolysis and ablation? Peripheral, pretty much every nerve, sensory nerve that you can target, that you can reach, you can target for pain control. We talk about intercostal, facial nerves, and any peripheral nerve sensory. Autonomic, I'm gonna mention the most commonly done, at least in my practice. What do we do for neurolysis and ablation? So there's Most commonly, two techniques: thermocoagulation, which pretty much refers to radiofrequency ablation. There are other techniques, like cryoablation, but chemical ablation, just think about the thermocoagulation requires some technology. Many pain centers cannot afford that kind of technology, just a radiofrequency. So in many centers, probably the basics and still safe and helpful refers to chemical ablation. So I'm going to mention a little bit about chemical ablation of some of the procedures that we do. The agents that we use are either alcohol or phenol. Advantage or disadvantage, you can read a lot of literature where some people are in favor of one versus the other. Overall, I think the balance favors alcohol. Advantages of phenol. What happened with phenol? Several advantages. You can inject that it's not expected to be painful, just to direct inject, not to be painful. Second thing, you can mix it with contrast. So when you inject the phenol, you can actually see the spread of the injectate. So probably those two. It's an agent that is not very affine for the nerves, which is what we're targeting. Seems to be more affine to the vascular structures. So it has a little caveat with that. When the phenol probably accidentally goes intravascular, it can have a lot of toxicity. It can have many side effects, including myoclonus, change in mental status, unconsciousness, arrhythmias, flashing, palpitations. So those can even cause renal and liver insufficiency that's been reported. So that's probably the downside of phenol. Alcohol in the other side. Phenol has to be mixed by a pharmacist as well. At least in the United States, you cannot just pull it out of the, out of your pharmacy and inject it. They have to mix it for you. Alcohol in the other side has other advantages. One, safe. If you accidentally inject alcohol intravascularly, maybe the patient will get drunk. I mean, that's the worst that can happen, but it's nothing else going to happen. Disadvantages, well, it's also cheap. Well, yes, it could be cheaper, but it's also something that doesn't need to be mixed by the pharmacist. Disadvantages is very irritant. So if you inject without blocking the sensation, it can be very painful. So you have to keep that in mind. In order to be able to cause ablation, the alcohol had to be in a concentration of 50 plus, of between 50 and 98%. Some other authors claim that could be lower, but that's pretty much the most important, the one that I see the most. I highlighted this because you have to make a diagnostic block before you ablate or neuralize anything. Multiple reasons. Number one, diagnostic. If you block something that you're intended to ablate or neuralize, but it doesn't have any effect, if it doesn't have any effect on the patient's pain, there's no purpose of doing the procedure. So you should always do the block. If the patient experiences analgesia, feels better, then you okay to go on with the ablation or neurolysis. The second thing is prognostic, because if you have injected the local anesthetic in other strokes that you are not intending to block, then that's a good safety reason to stop. Because if the patient is feeling numbness in an unanticipated area, or is feeling that you already caused a blocked nerve that is a motor nerve, then you should stop the procedure. And finally, for comfort, if I'm injecting alcohol in my patient, that's going to be very painful. So I still have to block it before I neuralize it. So now in the specific blocks, I brought this slide because I think it's very important to understand that the bone structures are very influenced by the sympathetic innervation. Sympathetic innervation is not just a vasomotor, it's also embedded into the sensory component of the bone structures. So for that reason, I think at least I use the stellar ganglion block mostly for my patient with upper extremity bone metastasis. So patients with a lot of pain in the bone structures, like lytic lesions, metastatic lesions to the upper extremity, I use the stellar ganglion plexus. Of course, I'm not going to discuss the whole thing. We use it for many other things, but in the cancer population, it's probably one of the reasons I use it the most. So what we're doing with this, we're targeting to block the superior, middle, and intermediate cervical ganglion. Many practitioners I know that are very comfortable doing this procedure with fluoroscopy. I never done it with fluoroscopy. With fluoroscopy, I don't see anything. I just see the bone. So But when I put the ultrasound, and I can clearly see where the thyroid, the esophagus, where the carotid circulation, the vertebral arteries, with everything else, I will be very hesitant. I will be very scared of doing it blindly. And again, I know many practitioners are comfortable doing. I'm okay with that, but at least in my practice, I don't do it unless with ultrasound. I see where the needle is. I see where the needle goes. I know when I'm injecting. So the picture in the left is a patient that I actually saw recently. It's a patient that I saw like 7 months ago. She's a breast cancer patient with a lot of metastatic lesions. For whatever reason, her most painful spot is in the arm. If you see, there has an active lesion into the left shoulder and the humerus. We did a stellar ganglion block. We just used local anesthesia, bupivacaine, plus triamcinolone. And she experienced 6 months of zero pain, complete pain relief of that area for 6 months. So we re-injected her a couple of weeks ago because her pain was coming back. But I was very pleased to see that for 6 months she was very comfortable with this pain. The needle placement, of course, is going to be, if you are unable to see the sympathetic nerves, the target of the injection will be in the anterior aspect of the longus colli muscle. You can see very well with the ultrasound. Complications, like everything, there's always chance of complications. However, you can tell that these complications that have been described in the literature most likely will be associated with procedures being done either blindly or with fluoroscopy. With fluoroscopy, you don't see any of these structures. With ultrasound, if I'm getting close to the lung, I'll see the pleura. I can see every structure. It doesn't mean you cannot have complications with ultrasound, but your chances are much lower. This is a patient with the Horner syndrome, which is what we expected. It could be a sign of successful blockade of the nerve. Some authors have used phenol. Some authors have used alcohol. Some authors have used radiofrequency ablation of the same structure. So if you feel comfortable with one of those, that's good. That's good to do. In my practice, I'm only doing steroids with the bupivacaine, and so far it's been very helpful for my patients. Now, I haven't done any retrospective to follow up and see the duration of the block, but overall, with good results. The next one is the celiac plexus, or now more commonly known as a deep splanchnic. It's probably one of my favorite procedures because it's so grateful. I mean, it's so rewarding to see the patients before and after. This procedure was described first in 1914, where it was for the first time blocked with local anesthesia. It took until 1957 when the first alcohol injection was done. From these two landmarks in history, many things have been done. Many authors, many experts have tried different techniques, different concentrations, different medications, but overall, the procedure is about the same. It's indicated to block these nerves we're talking about blocking the greater, lesser, and least sympathetic nerve blocks. So in this structure, you can see that they live behind the diaphragm right here. So one place that you can reach them is right here, or the true celiac block will be across the diaphragm. So in theory, it can block or it can target every structure from the distal esophagus all the way to the transverse colon. So most common patients that we inject, the pancreas cancer, liver cancer, contraindications, probably the most important, is small bowel obstruction. So that's the first thing you have to look. If the patient has a small bowel obstruction, you should not this neurolysis. So in my practice, I do the technique I'm going to demonstrate before, but I gotta show you that that's pretty much what we do the injectate. With this location, we'll probably be able to block all the nerves that we're targeting. Two most commonly described techniques, retrocrural and transcrural. Retrocrural is the one that I practice, and that's the one I can talk to you from experience, and that's the one for those of you sign up for the practice with cadavers, we can do this one. So that's it's a procedure that is safe, is effective. If it's done properly, you have to, it's simple, it's easy to do, but you have to know what you're doing so to avoid complications. I thought this is very important. I want to mention this because I know even in our department, there's a lot of variety. Everybody does everything differently, different volume, different concentration, different mixes, but I think it's important to mention this. The space with the splanchnic nerve leaves have been extensively studied in fiber optic, cadavers, and imaging, MRI and CAT scans. The conclusion is that each side of this space should be able to accommodate about 10 ml. So I thought that was very important to use this slide. So I know that I've seen people injecting a lot more. In my practice, this is what I do. I mix, first I inject bupivacaine, 4 ml, to cause anesthesia. That's my test. Is the pain getting better? Do you feel better? What percentage? 50%, 60%, 100%? When I know that I'm not blocking any other structure that I'm not intended, then I inject the alcohol, 7 ml in each side. So with total, what we're doing is 11 ml, which is not too far from what is recommended in the literature. And then with this mix, I'm doing 64% concentration. So I'm still in the range of chemical neurolysis with the appropriate volume. So the experts also recommend that with lower volume, you have less complications. The injectate should not be just spreading around the diaphragm or other structures, causing pain and causing other complications. So this is my recipe, what I do, pretty much very simple. But I wanted to show you this one. Just to show that, to demonstrate the complexity of the patients that we see. In this patient, for example, this is a lady who had this big sarcoma. I don't know if this structure is pelvic or is abdominal. So we thought it was maybe that maybe a splanchnic nerve block would be the right choice for her. We did that one, and she only experienced 30% pain relief. Then we moved to a superior hypogastric too. So we did the 2 blocks at the same time. With that one, she accomplished 80% pain relief. So pretty much what I'm saying is that many patients don't need just one procedure. There are patients that have done the lumbar plexus to control the bone pain. Then I had to do the splanchnic nerve block for the visceral pain. So you have to go case by case. I don't want to go into much details, but so pretty much before, first you have to square well the vertebral bodies. Then in an oblique view, after you cover the transverse process, hopefully entering a very gun barrel manner, your needle should be straight down. Then, as a safety issue, you have to touch the bone before you advance to the anterior aspect of the vertebral body. If you don't touch the bone, you shouldn't inject. You might be in the wrong space. So you have to touch the bone, and then in a lateral view, you advance the needle all the way to the anterior aspect of the vertebral body. At the point, this is the other side. At the point, you're ready to put contrast. I usually don't put contrast at the same time. I put one needle, and I do contrast. And then I know if I know that in the right spot, then I move to the other side. Because when you put both needles and you inject contrast, then when you're going to inject contrast in the other side, it's very easy that the contrast you already inject is going to be blocking the view of what you're doing. So if I have some time between one and the other one, the first one most likely has dissipated some, and then it's not going to interfere with the view of my second injection. So this is the proper needle placement. Then this is the contrast. The one thing that you should never see is contrast going backwards. That's probably when the complications happen. So the contrast should always go in a eggshell view, hopefully going up and not down, but this is the right spread of the contrast. In an AP view, this is probably what you're expecting to see. It should never be outside of the vertebral bodies. It's very common to see it in the lateral view. You see a good spread, but then you go into the AP, you can see a clear muscular distribution. Then you probably have to go back and relocate the needle. Then when you do this, after you inject the local anesthetic and the patient tells you, yes, I feel way better, then a few minutes later, you're ready to inject your alcohol. And then the procedure is done. This is a patient that was actually referred to me. One of my fellows scheduled the procedure. It was not my patient, but told me, hey, can you do this procedure for somebody? I said, no problem. So you have to look at your imaging. So it's also common, probably you hear from people, oh, the splanchnic nerve blocks or celiacs are for pain located from the umbilicus up. So the upper abdomen from umbilical button up. And that's what I was told. Oh, this patient has pain from the umbilical button up. Okay. And so if I haven't looked at the image, I think I could have potentially been into some complications. This patient has a huge tumor compromising the whole left side. If I had gone without looking at my CAT scan, this needle would have gone through the tumor, and I probably would have caused some tumor necrosis by injecting alcohol, because the needle was going to be all the way from here. So you have to look at your imaging. So the second thing is, like, if you look at this bone spot right here, many of our patients are older, and the vertebral bodies don't look perfect. So you have to look at those details in advance, because the needle could easily have been in the fluoroscopy, you won't be able to see those details. So the needle could easily be hitting this structure, and you won't be able to advance to the front. Then it's a procedure that's getting complicated, you're not unable to accomplish, you're not doing it right. In this patient, after look at the image, so we decided to do only one-sided. We did that right-sided, hoping that it was going to spread well to the front and the other side, and the patient did accomplish 70% pain relief. So we were very happy, because only one side, and it worked still well. This is the lateral view of that procedure. Complications, of course, there's always complications. It's a procedure with fluoroscopy, and there's always things that can happen. I put in white probably the mild complications, commonly expected up to 60% transient hypotension. That's why some people use ephedrine. Some of them use a prophylactic. The patient with a borderline blood pressure, they give ephedrine before the procedure. Some people prefer to wait if the patient goes hypotensive. Sometimes we use it intravenous. That's why we also give crystalloids. The patient gets some normal saline or other solutions, so to try to bring the blood pressure up. That's usually is usually transient, and it's also a good sign of effective blockade, because we're blocking the sympathetic drive. Diarrhea is an unopposed sympathetic block, so the patients can have transient diarrhea. It's described it can last around 48 hours, but it can be longer than that. 60% of the patients can get that. Hematomas, we put in needles, so it's very common to have a local bruising of the soft tissue. Then in the next color, I displayed the moderate complications. Intravenous injection, I mentioned from alcohol, probably nothing to worry. Infection, I haven't seen anyone, but it's possible. It spread to somatic nerve. One of my patients, the procedure went okay, the test was fine, but then on the follow-up, we found that the patient had numbness in the gluteal area. So it looked like just one of these. The most common areas of spread of this of the alcohol is T10, T10-2L2, most commonly. So I expect those somatic changes into that distribution. Ejaculation failure 2%, and some visceral injuries, and pneumothorax. If you're going in, I usually approach this procedure at a L1 level, and it's unlikely, but I see in many patients that patients with COPD or air trapping conditions where the lung can be very low, and even at L1, you might still be able to cause pneumothorax. But some practitioners go straight to the T12, so your chances of pneumothorax are much higher. Epidural intrathecal injection has happened. And in red, I also put probably the most significant complication was paraplegia. At least a dozen case reports have been published about this. It seems to what I looked at that this is nothing even related with the technique. So if you are unfortunate enough and it happens to you, even in procedure done with a pristine technique, it can happen. The explanation is probably because you can cause an spasm of the arteria radicularis magna, the Adam-Kuwix artery, and then it can happen. Unfortunately, I have to confess that I don't mention that to my patients. Probably in one way because I want to help them. If I tell them that, many patients rather endure pain than go through the procedure. And I'm not lying to the patients either, but it's a controversial thing that you have to display to your patients. I think they have the right to know that anyway. The next block that I want to mention is the sympathetic lumbar plexus. Going back to the bone structures, patient with the lytic lesions and bone pain from metastatic lesions. That's probably the main indication why I use this nerve block, is also to try to block the sympathetic mediated part of the pain. We're not doing motor pains, but motor nerves, but the sympathetic nerves are distributed with other nerves, and you can see there's multiple areas of the lower extremities that can be covered with this type of block. This is one that I did recently. It's a lady with scoliosis and a lot of pain, metastatic lesions. She had a fracture in the femur, metastatic lesion. Orthopedics were not going to do anything at that point, fixation of the fracture. They put in a wheelchair to say avoid weight bearing. And I decided to do the lumbar plexus block for pain control. It worked pretty well. Her spine is not the most, the most anatomically friendly, but the spot where you put this is in between L2 and L3. I usually target the disc area. In that area, you can enter in an oblique fashion as well with the do it intradiscal. You can see the injectate here. Usually this block takes a large volume. Some people do up to 15 ml. I do 10 ml of a mix of local anesthetic with steroids. There are other people also doing a radiofrequency ablation. So it's up to you. All of those tools you can put in perspective. Whatever you feel comfortable with and whatever you think is best choice for your patient, that's the one you do. This patient also experienced a very good pain relief. She was doing well until the last time I saw her 2 months after the procedure. The next one is the superior hypogastric plexus. Dr. Chai tomorrow is going to be into the cadaver workshop to demonstrate this procedure. With this block, we're targeting other structures from descending colon to rectum, bladder, prostate, etc. So with this nerve block, pretty much the same concept. You should always do diagnostics. You put local anesthesia to see the patient has a pain relief, and then you can follow with the alcohol. There are different techniques being tried. I want to mention this first. Anatomically, 90% of the patients, the plexus seems to be more lean to the left. So when I'm doing this procedure, I always do the left first. Because when I do the left, I put the needle and I do the local anesthesia. If the patient tells me that it's complete pain relief, I don't have to do the right side. So I'm saving trauma for the patient and additional radiation and everything else. So it's 80% on the left. So I tried that one first. I thought it was a good tip to mention that. Some other people, like Dr. Chai, for example, he does it all the time, right? Transdiscal. If you decide to do transdiscal, be aware of the need for antibiotics. Some practitioners give systemic and intradiscal. I've probably done it twice for transdiscal. I have better luck with the other approach, so I don't do it transdiscal, but he's going to show you that tomorrow. For this, my mix is very similar. Now the volume, there's not really any anatomic review telling me what is the volume you can accommodate in there, but if you look at the structure here, very tight with the tumor, probably I will expect not to put too much alcohol. So what I do, I apply 3 ml in each side, and after I see the results of the pain relief, I go with alcohol 4 ml. In this range, the volume is not too high, and still the concentration is about 50%, so expected to cause neurolysis. The target of this block will be in the inferior aspect of the L5. What I actually do, I target more this space right here around the disc. So I enter between the L5 and S1. Probably with the tomorrow with the cadaver will be more. It will be easier to explain. But in this case, the needles are located in the inferior aspect of the loom of the L5. I usually enter the needles in this area, and then I try to go up to touch the lower border of the L5. At that point, you put the contrast, and then the same thing, alcohol, then the injectate. Transdiscal approach, Dr. Shah will tell you tomorrow, but so pretty much in this view, you have to put the superior arterial process in a way that the disc, this area will be the disc. You put in a oblique projection with the needle is located between the external and middle third of the disc. So that's where you need to enter. As you're gonna feel the rubbery feeling through going through the disc. Then in the lateral view, as you advance, you're gonna see that you go in transdiscal. And then that's the location of the needle, the spread of the contrast, and finally the alcohol. And that's probably what it will look like in the front. Complications, most common complications besides visceral vascular injury, sexual dysfunction, incontinence. I've seen I've seen at least 2 patients that got this nerve block and they got incontinent. Lucky this is something that is reversible. Over time they will recover that if it's procedure related. But also very common painful dysfunctions from nerve injury, either from the alcohol or from the procedure. The last one I want to mention, the ganglion impart. This one pretty much targets the sympathetic plexus in the most distal area. It's intended to cover this structure from anus, perineum, urethra, scrotum. The technique would be you go in a lateral view, the needle to go across the sacrococcygeal ligament. You have to be very careful because as you put the needle, you're almost right there. If you're just trying to feel the touch and try to go, many times I've seen that the needle is already way down into the pelvis, so you always have a great chance of perforation of bowel or other visceral. So you have to apply the needle and with fluoroscopy very closely see the tractor needle, make sure that it's not very deep. This is a good picture where the spread of the contrast is, and then in an AP view, you see the location of the needle. You're hoping that the spread is very midline. This is the mix that I use for that. Bupivacaine 3 ml plus alcohol 4 ml. Is again to keep the concentration in the 50+% in order to cause neurolysis. The last thing I want to mention is about the vertebral augmentation. It's probably my favorite procedure together with the splanchnic nerve block. In MD Anderson, we do quite a lot of these procedures. It's also very rewarding because you can see the patients before and after. This procedure is intended to be only for pain and most commonly for metastatic lesions from different cancers. 70% of those are thoracic, 20% lumbar, 10% cervical. So in my cancer patient, when they develop thoracic axial pain, high suspicion for metastatic disease, depending on what kind of cancer, but this is something that shouldn't be pain. In the thoracic area cancer patient, you have to watch out. In a multiple myeloma patient, it's pretty much a primary location of the tumors in those patients, most commonly between T6 and L4. This is pretty much the area where I feel comfortable doing the kyphos. Anything about T5, sometimes even T6, the pedicles are very small, and I prefer to refer those patients to interventional radiology. They can do it with the CAT scan guidance, so I don't, that's a technique that I don't know. 50% of those will be between T11 and L1. In MD Anderson, the numbers are a little bit different, so 49% of the patients are with myeloma. We see a lot of patients with osteoporosis, compression fracture. They happen to have cancer, and even if this is not metastatic, they also have osteoporosis. They get a compression fracture, and that's also like a big number. Metastatics apparently is only close to 20%. So one thing to mention is that very important, one more time, this procedure is exclusively for pain. We're not treating cancer, we're not ablating tumors, we're not trying to remodel the structure of the vertebral bodies. If you can do that, that's great, but this is only exclusively to treat pain. So where at this time, the pain is presumably coming from the inflammation and the periosteum stretching. It's a patient that cannot move because then the pain is severe, just moving the axial structures. So the pain reduction is the target and is very effective. Some literature talks almost up to 100% of pain improvement of these patients. Of course, quality of life will be completely changed with this type of procedures. So what we use the polymethyl methacrylate, which is this is the cement that we inject. In theory, what it causes is an exothermic reaction, so it causes some tumor ablation, also some nerve ablation, and mechanical stabilization. When I talk to my patients, I tell them it's like I'm going to put glue into your vertebral body, so the unstable part of the bone with that particular material should solidify, and also with the neurolysis, that seems to be the reason why it works. The efficacy, kypho versus vertebroplasty. Kyphoplasty uses balloons, vertebroplasty no balloons. It's in the second picture. Of course, kyphoplasty is more expensive, it's more laborious because you need more equipment. multiple papers published. Of course, if you can expect, many of those papers that you see are sponsored by the industry, the ones that are selling the product. So you have to be very careful when you read the literature because each one will be pushing to their own side, to their equipment. But efficacy-wise, they seem to work the same. I was looking at a big review of a large number of patients that were followed up with both. Vertebroplasty appear, at least in the statistics by numbers, appear to be more efficient for pain control, but associated with more complications. Kyphoplasty more expensive and more laborious. In most of my patients, what I do is kyphoplasty. So the efficacy is being demonstrated. It's a very good procedure. It's considered minimally invasive and safe. If I'm a patient, I probably rather take this than a big surgical stabilization by an orthopedics with laminectomy and who knows, fusion. Interesting, the trend is that now probably unilateral goes better than bilateral. Some authors say that it's actually better. If you think about it, what the concept of the neurolysis stabilization, that goes with that. I have a lot of patients that are done the kyphoplasty and technical difficulties. You're trying to make it big and beautiful, doesn't work. Some of the patients, when you see the cement start going backwards, you stop. Some of those patients have only got 1 cc of the cement, and then after the procedure, patient is pain-free. I'm like, wow, it was only, I could barely put any cement and it still works. So that goes again with probably the mechanism of effect, is neurolysis and stabilization of the bone. How many levels? I was also reading about this. Some experts said you shouldn't do more than 2 levels. Others said up to 3 levels. I know in our institution, I haven't gone more than 3 levels in the same patient, but I've seen cases where even 5 levels were done at the same time with bilateral approach. Some of them, they discussed that the PMA toxicity. I tried to look at what the PMA toxicity is. There's nothing systemic. I couldn't find anything that's saying that PMA causes any systemic toxicity. What it goes is more about the local tissue and irritation in the area of where you inject. So I put that maybe as a question mark. Is it really a PMA toxicity? Maybe I just don't know. Safety-wise, I mentioned before, probably the vertebroplasty is associated to more complications. It's a safe procedure if it's done with the right technique, with the proper training. Cement leakage is the most common complication. Lucky that only 2.6 of the patients in big paper reviews are symptomatic. Usually those symptoms are transient. Most common cement leakage is in the proximity of the procedure, but have been cases described with the spinal cord injury from the cement injection. When you inject in the cement, you always need to look in live fluoroscopy that the cement is not going backwards. That's the first indication to stop the procedure, and that's what I do. Radiculopathy, the cement can go into the foramina or to other locations of the proximity of the nerve. And there's been many cases where the cement actually goes intravascular and causes pulmonary embolism. This is a good picture of a kyphoplasty. The vertebral body looks very stable now with the cement injected there. I think that's all what I wanted to mention. I just wanted to mention there are many other procedures, there are many other techniques, there are many other devices. It's overwhelming. So in the United States, in our department, you can see that you can get overwhelmed with the amount of information and the industry trying to sell you a new product, a new way, a new technique, a new everything. Obviously, we're talking about money. Many of those have no been studied in any respectable trial. So when you get those things offered and you feel like encouraged to use it, always question yourself and see if this is the best thing for your patient. In summary, so as I mentioned at the beginning, cancer pain doesn't necessarily mean cancer-related pain. Many of those pains, and I don't know the answer, what's the percentage, many of those pains in the patient with cancer has nothing to do with the disease. So you don't have to treat every pain in the cancer patient as cancer pain. So the management of the cancer pain patient should be multidisciplinary and multimodal. If you choose to do only narcotics, you're going to be dealing with the narcotics. If you choose to do only procedures. Procedures fail, procedures have complications, and procedures many times, even that we think that we did the procedure with the perfect technique, don't work. As many times that you're expecting the results to be there and it doesn't work. So you always have to have a plan B for your patient. You're doing the procedure, but you also have a plan B to cover if the pain is not improved with the procedure. So always remember to do a diagnostic or prognostic block before you ablate the patients. They can be done with different techniques and chemistry and chemicals, but this is very important. 14% of the patients don't accomplish pain control, even in the hands of the best experts. So it's frustrating. So many times you think you're doing the best, you do it with probably the most knowledgeable person in present, and probably with the best technology, the best medications, the best everything, and you still you find out that patients don't have the outcome that you expected. So with this, thank you for your attention. If you have any questions, please.
We have 15 minutes more. Do you have any question? Or anyone want to share any experience? Oh, please, Professor.
Hello. So whenever you do neurolysis, it's very important that you don't damage the nerve. Okay. So the study shows that above 50, if you use a higher than 50% alcohol concentration, you have a much higher incidence of knocking out the motor fiber. 50%, if you use exactly 50%, your chance of knocking out motor fiber is much, much less. Okay? So that's why Dr. Roland tends to stay closer to 50% as possible. Okay? Yeah. So, and the phenol is, when you compare alcohol and phenol, okay? Now alcohol is like water. It's not the viscous. But phenol is mixed with glycine, which is like honey. It's so viscous that you have to use a very large needle in order to inject that. Okay? So large needle means more trauma for the patient, higher chance of complication. That's why we discourage using phenol for the neurolysis. Alcohol is much better, and you can use a smaller needle. Usually you don't need anything bigger than 22 gauge. That's a comment.
We used to have phenol in Sirirat, but now we only have alcohol for neurolysis. So just share experience in Sirirat that actually we have a less case for intervention for cancer pain because most of the case is for celiac plexus block. Like Dr. Nantason do the splenic blocks, but for me I do the celiac plexus block. It depends for preferable, but I found that it's very difficult to find a suitable candidate for the lower pelvic pain, or especially when they came with a very large cancer of the endometrium or the big pelvic mass or something like that. So, if you have any experience to share, Dr. Karina Lee.
In Hong Kong, we also now doing more splenic block, higher level, because we found that for lower esophagus, or some patients with liver metastasis with distension of the diaphragm, the upper part, and it's just the celiac block is not enough. And higher splenic block, we found the result is excellent. And to do it more safer, to avoid pneumothorax, nowadays we combine the use of ultrasound. Because ultrasound is perfect to see the pleura. And so we actually do it, similar as paravertebral block, transverse pain, but we take away the image of ribs. Then you guide the needle in. Once the needle passes through the pedicles, or near the pedicles, I mean, like what we do for paravertebral block, then you have the X-ray in and do it under II. So I find it is very safe, and then it's very safely, you don't get pneumothorax. And this is a very good way we do, and the result is good. And another thing is that I work in private practice, and I have a lot of patients come out also very late. And before intrathecal implantations, well, the whole abdomen having metastasis, and I do see patients that have the whole abdomen having the metastasis, and they're rich, and so they can have, like whole abdomen radiations, and together with biologic or target therapy and triple antibiotics, and to conceal the tumor just within the peritoneum. And this kind of patients, if they come a bit earlier, not for intrathecal, then I find it the combination use of celiac and then the hypogastric together with the ganglion implant if they are down to the pelvic. And there has been some papers, published, the combination block sympathetic for the whole abdomen at 3 levels is excellent. The effect is very good, and the patient don't need the intrathecal catheter, and because you never know, they not justify for intrathecal implant, but you don't know how long they live. So right. I rather repeatedly do the neurolytic block, and I have experience for celiac practice block. I have done 3-4 times for one patient. And I think this is something really good. And I noticed that as long as you repeat the block, and it's just like the main tree of the branch of the trees. You cut it one time, the nerve regenerate more little. The branch won't die back because they have malnutrition as well. So when you do it 3rd time, actually most of the pain can be controlled with simple opioids. That's my experience.
So whenever you are relying too much on this kind of neurolytic block, sometimes you get disappointed because depending on what type of pain they have, somatic versus visceral, sometimes you don't get any efficacy. Okay, so you have to have a plan B. That's like Dr. Roldan has mentioned. Okay, sometimes combination, some order, yeah.
They still need a sound mind to make very major decisions.
But cancer pain does not know whether you're rich or poor.
No, I mean that is that this, because it's the options.
Yeah.
It's still that for interventional, if patient need to get into the theater to do it, then that's why we need to think, the cost of very nice potent opioid like Targin or OxyContin is also very expensive, isn't it?
Right.
So that's why the choice between neurolytic block, intrathecal pump, and the opioid, I think is also very important to calculate the cost.
That's right. That's right.
And whether the patient can go home and enjoy life with the family, I think with a sound mind, reasonable appetite, is also all very important. Yeah.
Okay, thank you. When I heard about the series of block, just remind me of the patients in Thai patient. Do you have about Dr. Not? Do you think the same? When we have patient for intervention, especially for cancer patient, sometimes they're very fatigued, they're very weak, and some of them sent by the surgeon. So for the first step, they were persuaded by the surgeon, okay, and come to us. It's not difficult to persuade them to have some blocks. But then if you introduce some other series, the Thai patient is just, they are not very keen for a lot of intervention, especially an invasive procedure. So we try to tell them, okay, what's benefit and what in our statistic that, okay, that's the most benefit for you. And if they have a less pain or mild to moderate pain, they say, okay, I think about it. So normally I will just introduce a concept. Okay, just think about it next time when we see each other, and then it's come up with okay, you can tell me, okay, what do you think about the idea? And how about, we still have some time, or we can discuss about this more. Do you have any question for Dr. Carlos? now this day they said we have very good education for fellows. The oncologist sent the fellow in oncology, oncogyne, to have elective in our pain clinic. And now they are very keen to send patients to us, but we don't have a joint clinic.
I think if for better collaborations and better plan for the patients, because sometimes they didn't understand what we are planning for them,
Right.
and you don't know what's the plan there for the patient as well, because sometimes they suddenly become very have new drugs or with the target therapy,
Right.
immunotherapy, and they have very fast changing, for different kinds of therapy can offer to patient. Even for stage 4 cancer, I can see patients live up to the 3rd year or 4th year. So it's good idea. In Hong Kong, we are
Yes.
getting more public hospital having combined clinic
Right.
with oncologists, and we have very get that we have 2 palliative oncologists into our Pain Society Council. So,
right.
so we have a lot of scientific meeting with the Palliative Society together with the Pain Society. I think the Thai associations can consider, have more collaboration, and then at the end up with more, combined clinic. It's very good.
Yes, that's very good idea. We have some project like a healthcare plan. Now we're starting with the cancer pain, but join with the orthopedic surgeon, and but for it's like we audit for the quality of pain management as well, but not yet that the joint clinic, but we try to.
Yeah, it has been always a problem, even in the United States. To a large degree, oncologists practice pain management. Okay, so they have experience.
Yes.
You can use morphine. 90% of the time, they get better.
Yeah.
Okay, so this few percent of patients that are having refractory pain,
Right.
they were sent to us. So if you look at Sloan Kettering, I saw their publication. Pain clinic manages 0.3% of pain patients in their hospital.
Right.
0.3%. Okay, Anderson is also single digit, maybe 3%. Okay, palliative care or supportive care handles majority of their pain, and
Yes.
they do okay.
I don't have the numbers for Thailand, but anyone want to share experience?
I think those patients, they just drop out from the medical system. They seeking like for Asian or Chinese, they seek a lot of other alternative medicine. They just want to go home. So I don't think they are okay, because from the studies, well, a lot of cancer patients, they do still have 60% to 70% of severe pain, moderate to severe pain. That's what we saw it, but we didn't see the patient. Why? Because we didn't get the referral.
That's right.
So we need to be friends with them, and they understand what we can help them, because sometimes they get stuck. They didn't know that we can do this kind of very nice
right.
neurolytic procedure. They didn't know at all. They didn't
right.
see one. If they see one, they will keep refer.
In fact, Anderson is so big that some oncologists don't even know there is a pain clinic.
Really?
Okay, so we have to make ourselves more visible. We go roadshow. Our faculty is asked to knock on every department and give them lectures. Okay, and we when we do research,
Right.
we intentionally try to collaborate with the other oncologists. Okay, collaboration, and then sometimes the IRB demands multiple teams involved in any research. Okay, so that's one way to make yourself more visible,
Right.
and it's all for our patients. Our patients suffer. And many
Yes.
times when we see this oncology referral, we have to scratch our head. What they've been doing to patients with the pain management. It's incredible.
Right. Thank you, Prof. Professor Vanna want to share.
In Sri Lanka, our oncologists have the pain they have the knowledge about the pain management especially in the young staff that they have there. They mostly send the patient to our pain clinic when they have nothing to do. with the patient. That means no
It's true.
chemotherapy, no radiation, nothing else, and then okay, they invite or persuade the patient, refer the patient to our clinic, and most of the patient expect that okay, our clinic have the last chance for them to cure everything. So we have to talk about that. Okay, we only pain relief is not cure the tumor because some of them doesn't know. And this is I think it's when we saw the patient, we have to know the whole person, not just only cure pain. We have to advise, educate, and also in our pain clinic, we have the palliative clinic. Ajan Binjoyu in the same. We have palliative care in the same unit. And so if if the patient have the problem about cannot go to see the clinic for the appointment, okay, we refer to the palliative care because the palliative care they have the continuing to go to see at the home and can take care, look after the whole family too. This is the problem is in Thailand is the patient came from the distant province, another province, and when we refer back to the province, they did not receive the medication. That's the problem, and they have to come to the Sirirat to receive the medication. Sometimes they did not bring the patient, just only the relative come to our hospital. But by law, if you did not have patient, we cannot prescribe opioid. Because the police told me that if you prescribe the opioid, that means you sell the drug. You did not treat the patient. This is a very difficult problem. Yeah. And so if we have the relative and know the patient for a while, maybe sometimes we accept, okay, this time the patient cannot come, okay, the next appointment, please bring him or them to the clinic to let us to see the patient is alive or not. Okay. Yes, this is for the sharing. Yes.
Yes, even for our cancer patients, if they're receiving opioid from us, they must show up every 3 months minimum. Yeah, we have to make sure they are alive. Number one. Number two, so we can monitor them. We take their urine samples and make sure they are taking opioid. If urine shows no opioid, then they don't get opioid refills. Okay? That means they're not compliant.
Yeah, we haven't done the opioid consent for cancer patient yet in Sierra, but we do in the non-cancer patient. So anyway, the cancer issue is a biopsychosocial issue. We have a lot to discuss. We don't have enough time, so anyone want to ask the last question for Dr. Carlos? Okay, if there is no one, so I will thank you, Dr. Carlos, for your comprehensive lectures. Just come back to Dr. Salaset. He have some issues just to announce.
Okay. Ready, you can contact with the front desk and please checking your spelling, your name spelling, if it's correct or not. If it's not correct, please contact us. The second thing that for the one who will join the workshop tomorrow will held in the another building, which called the C. Surindra building. It's a very colorful one with the bank at the basement floor. Okay, and last but not least, please don't forget to help us improve our conference by doing the evaluation from via the QR code and be a part of the lucky draw in this evening. Okay, and now we have a 15-minute break. This break we will have a really delicious meatball grill from pork and also the sweet crystal sticky rice. That's also really delicious also. Okay, เบรกบ่ายนี้มีลูกชิ้นหมูปิ้งกับข้าวเหนียวแก้วนะครับ Okay, let's enjoy our break and please join another interesting session in 15 minutes. Thank you.